This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 14, OB GYN Emergencies. Introduction. 99% of all out-of-hospital deliveries occur without complication. During and after delivery, out-of-hospital treatment for both the mother and the infant is usually supported. Providers must rarely encounter a potentially fatal obstetric emergency. Understanding conditions and treatment is key to success. Now, this is the pharmacology section for OBGYN, so we will be learning more whenever we actually hit the treatment modalities. Preterm labor, defined as labor beginning between the 21st and the 37th week, occurs 5 to 15% of the pregnancies. Most common complication and exact cause of this is actually unknown. So preterm labor medications, we have tocolytics, which essentially relax smooth muscle. So these are going to be beta agonists, just like some of our asthma medications are. Decrease or inhibit the uterine contraction. An example of this, beta-2 inhibitors like Terbutaline or albuterol. Albuterol isn't utilized. It's more utilized for lungs only. Calcium channel blockers, examples of this would be nifedipine, and that would be to control blood pressure and or contraction, smooth muscles. And then oxytocin blockers, which oxytocin or pitocin is what the body secretes to initiate the contraction, like atospan. Criteria to determine tocolytic therapy. Live fetus gestational age less than 35 weeks. Estimated fetal weight loss less than 2,500 grams. Membranes are not ruptured. And cervical dilation is less than 4 centimeters. And effacement, which would mean that the cervix is completely effaced, 100%, is less than 80% on this. No problems that require immediate delivery, like no distress to the fetus. Postpartum hemorrhage, defined as blood loss greater than 500 milliliters, and occurs within 24 hours of delivery. Initial treatment, standard hypovolemic regimen, would be airway, IV access, and volume expanders if indicated, normal saline lactated ringers. Pharmacological therapy, oxytocin is a drug of choice. And generally speaking, there's probably some after products of birth still left in the birth canal that is causing bleeding. So the oxytocin would cause it to contract out and eliminate out, and then the natural clotting process would take place. But it needs to be caught early. We can't bleed for 24-48 hours and then discover this. Naturally occurring hormone increases uterine tone and decreases blood flow. Delayed treatment exacerbates life-threatening situations, and they'll essentially bleed out. Preeclampsia, hypertension of pregnancy, found in about 6 to 8% of the pregnancies worldwide. It's poorly understood, and it possibly might be a placental protein endothelium reaction. Characteristics: hypertension, systolic pressure greater than 140 millimeters of mercury, and a diastolic pressure greater than 90 millimeters of mercury, and protein found in the urine is how we generally identify this. Preeclampsia to eclampsia generally occurs during the last trimester. It's rare, 1 in 2,000 pregnancies, usually preceded by preeclampsia, so you kind of get a warning notice, but not in all cases. Characterized by acute hypertension, and that would be a systolic blood pressure greater than 140 systolic, or diastolic blood pressure greater than 90 millimeters of mercury, with tonic-clonic seizures, and usually fatal if untreated. Treatment of eclampsia and preeclampsia: lay them on their left side for positioning, and that's to stop postural hypotension. The abdomen and the fetus has grown large and carries some weight to it, so if we clamp off the central venous side, it will decrease the preload to the pulmonary trunk. If we put them on their left side, the artery or the aorta can take a little bit of compression. Early control of the airway, early IV access, and protect the patient from injury during seizures. Drugs that we use to control preeclampsia and eclampsia. Medications control essentially blood pressure and prevent progression of the pregnancy. And what I mean by that is I shouldn't have said pregnancy so much as uterine contractions. We use these medications to stop or slow down uterine contractions. Beta-2 adrenergics like Terbutaline are utilized. These are called tocolytics. And they would decrease the uterine contraction by relaxing the smooth muscle there. Calcium channel blockers do this as well through blocking the calcium channels and relaxing the smooth muscle. Oxytocin blockers would actually stop the trigger, and things like hydralazine would control the blood pressure, and that would be Preterm. Medications used to control the eclamptic seizures. One of them is Mag Sulfate, which we have a larger dose than we do for cardiac and Mag Sulfate. And the other one is Diazepam, or Valium. Valium is very helpful. It's a GABA agonist. It controls the chloride intake and thereby reducing overall seizure activity or electrical firestorm generation by synapses. OB GYN medications, we're going to talk about Diazepam, hydralazine or Preterm, Magnesium Sulfate, Oxytocin or Pitocin, and Terbutaline or Breathine. First one, this is a primary care medication. Generic on this is going to be Diazepam, and the trade name is going to be Valium. Diazepam is a benzodiazepine whose exact mechanism is unknown, but many believe it appears to act on both limbic and subcortical levels of the CNS. Principal use of the anticonvulsant properties. It suppresses the spread of seizure activity through the motor cortex of the brain. Does not appear to abolish the abnormal electrical discharge focus. It is also used as a sedative in the management of stress and anxiety. We consider this a benzodiazepine and a GABA agonist. Diazepam is an effective skeletal muscle relaxant, making it an effective adjunct in managing orthopedic injuries. Also useful as a pre-medication for minor surgeries and cardioversion because of it induces amnesia, which diminishes the patient's recall of the procedure. Adult dose on this for seizures and status epilepticus is going to be 5 to 10 milligrams IV, slow IV bolus. May repeat every 10 to 15 minutes as needed for a total of 30 milligrams. Be aware, higher doses of this drug may cause respiratory depression. May be administered IM if unable to obtain IV access. Skeletal muscle relaxant 5 to 10 milligrams. Skeletal muscle relaxant in the elderly 2 to 5. So as they get older, please reduce the amount by about half. Contraindications, and that would be over the age of 70. Contraindications, hypersensitivity to diazepam, benzodiazepine, or propylene glycol, pre-existing CNS depression of any sort, and that includes alcohol intoxication, and narrow-angle glaucoma. Pharmacokinetics onset in 1 to 5 minutes with a duration of 15 to 60 minutes, and this is excreted in the urine. Preterm, general knowledge, we don't generally carry this in EMS, but again, general knowledge, so please look at the mechanism of injury. Hydralazine reduces blood pressure mainly on its direct effects on the vascular smooth muscle and arterial resistant vessels, resulting in vasodilation. Its hypotensive effects may be limited to sympathetic reflexes, which increase heart rate, stroke volume, and cardiac output. The postural hypotensive effect is reportedly less than that produced by sodium nitroprusside, and this works really well. It works on both the arteries and the veins, and reduces overall blood pressure to the vessels, thereby reducing the hypertensive event in pregnancy. Anyway, so this is general knowledge there. Please be aware of the mechanism of action on this. Magnesium sulfate, this is primary care. Generic antitrade or magnesium sulfate. Acts as a physiological calcium channel blocker, blocks neuromuscular transmission when given parentally, and this would be IV, IM, sub-Q. We don't give it generally sub-Q, we give it IV or IM. Blocks the neuromuscular transmission when it acts as a CNS depressant and also a depressant of the smooth skeletal and cardiac muscle function. This is going to inhibit calcium influx in all of the areas that calcium is utilized in. That includes skeletal muscles, autonomic muscle, and so on. Anticonvulsant properties by decreasing the amount of acetylcholine liberated from the motor nerve terminals, thus producing peripheral neuromuscular blockade. Adult dose in this is going to be 4 to 5 grams by IV infusion, concurrently with up to 5 grams IM in each buttock, then followed by a 1 to 2 gram per hour continuous infusion, and do not exceed 40 grams per day on the magnesium sulfate. Contraindications: do not administer magnesium sulfate to patients with hypermagnesemia or high magnesium or low amounts of calcium. and heart block. Pharmacokinetics, it onsets immediately, duration is about 30 minutes, and it's excreted in the urine. Oxytocin, this is going to be a primary care. Whenever you get to, they may use Pitocin on individuals whenever you're in labor and delivery, so that's why it's a primary care. Generic on this is going to be Oxytocin, and the trade name is going to be Pitocin. Mechanism of action, synthetic compound identical to naturally produced pituitary hormone. Stimulates uterine contractions and contraction of uterine blood vessels to reduce postpartum bleeding. This is also Pitocin, what they utilize to stimulate the uterine contractions to get kiddo out, so they induce labor. Adult dose on this, IV, 10 units infused at 20 to 40 milliunits per minute. IM 10 units after delivery of the placenta. So 10 and 10. Contraindication, hypersensitivity to it, and we don't want to run it in too fast. So the IV bolus in the initial, please keep it to 20-40 milliunits per minute, or ask your nurse when administering, or what the hospital protocol is. Pharmacokinetics, onset 15 minutes, duration 1 hour, and would be the IV version, excreted by the livers and kidneys. Excreted by the liver and kidneys. Terbutaline, general knowledge, they don't use this so much anymore as a tocolytic agent. They like nifedipine if they're going to kind of decrease contractile force strength on a long-term basis. But I need you to know the mechanism of action in case someone still uses this. Terbutaline is a beta-2 adrenergic agonist. Now this is going to be the same thing as we're going to see in albuterol. Beta-2 adrenergic agonist, having strong effects on the pulmonary receptors. Terbutaline relaxes bronchial smooth muscles and results in an increase in lung capacity and a decrease in airway resistance. Now this is the bronchodilator mechanism of action. However, it does the same thing on all smooth muscle. The uterus itself is made of smooth muscle, so thereby it reduces overall contraction. Nasty side effect of terbutaline is it makes the heart beat harder, faster, stronger. It gives us beta-1 properties. So we can actually see the heart rate pick up very, very rapidly when utilizing this. Adult dose subcutaneous is 0.25, and this can be repeated in 15 to 30 minutes. Again, general knowledge drug, not utilized so much anymore. Well, in conclusion, most of the out-of-hospital obstetrics and gynecological emergencies do not require pharmacological intervention. The out-of-hospital professional can manage the majority of these emergencies by maintaining adequate airway, supplying supplemental oxygen, and administering IV volume expanders. Preeclampsia and Eclampsia are relatively rare. Out-of-hospital treatment is focused on the fundamentals, so let's bring down the blood pressure and let's see if we can stop the contractions if necessary. Medications can be critically important to patient outcomes. Thoroughly understanding these conditions improves our ability to apply these protocols appropriately. References for this chapter were taken from Beck Pharmacology for EMS Providers 198 to 205 of Del Mar Learning, and Bledsoe, Pre-Hospital Emergency Pharmacology 7th edition. If you have any questions concerning this chapter, please feel free to give me a call. My name is Roy Smith, smith@imsa.net, or 405-219-7613. Thank you.